Assalamualaikum and very good morning to everyone here. So welcome to the breakfast at UMHealth episode 17 today. So I'm Dr. Mukhri from Department of Obstetric and Gynecology, and I will moderate the session today. And in this morning, we have two eminent speakers. One is from the Department of Obstetric and Gynecology, Associate Prof. Bali, and the next one will be Dr. Siti Masyithah. And let us introduce the first speaker. So Associate Prof. Dr. Vallikkannu Narayanan is one of our consultants in Obstetric and Gynecology with the subspecialist in fetal and maternal medicine. And she has a huge experience in managing maternal and fetal cases in our department. And without further ado, I would like to invite Prof. Vali to deliver her talk on congenital heart block. Prof. Vali.
Yeah, okay. Thank you, Prof. Mukhri, for the kind introduction. The topic for my presentation today will be congenital heart block. Very good morning to all the participants. You might be thinking what an obstetrician is going to talk about heart pathology. Well, actually, our patients that we see with the heart problem are the fetus in utero. Okay, so I'm going to talk about the congenital heart block in today's presentation. So the causes, it could be autoimmune antibodies. Okay, so we are seeing patients who have SLE and Sjogren syndrome, who have the autoimmune antibodies, and then the fetus is affected with congenital heart block. But the other causes of congenital heart block could be fetal factors like structural abnormalities in the heart, like heterotaxy syndrome, transposition of the great arteries, and atrial or ventricular septal defects, tetralogy of Fallot, pulmonary stenosis, etc. And some of the maternal factors could be either type 2 diabetes, or the mother could be on drugs like anticonvulsants or lithium or NSAIDs, or the mother could have viral infections like Coxsackie virus, cytomegalovirus. So, but today I'm going to concentrate on this autoantibody transfer. So when the this is called autoimmune congenital heart block. So what happens actually is autoantibodies from the mother, they cross the placenta and then they affect the fetal heart. So they affect the atrioventricular node in the fetal heart, and then there could be inflammation or calcification or fibrosis, and hence there is complete heart block. This could be because of the mother having the anti-Rho and anti-La antibodies. So by definition, mother who have autoantibodies, and then if there is any absence of other causes of congenital heart block, they could be diagnosed by fetal echo in utero at birth or at the neonatal period less than 27 days of life. So usually SLE and Sjogren syndrome are the causes for this autoimmune congenital heart block. So the clinical criteria for SLE could be either they could present with mala rash, or photosensitivity, oral ulcers, or arthritis or serositis. Sometimes they could even have some lupus nephritis or neurological disorder or hematological disorder. So the, the genetic, the environmental, or the immunoregulatory or the hormonal factors could cause immune complexes and cytokines, which could lead to a multi-system disorder. They could present with seizures or psychosis or neuropathies. It could affect the lung or the heart, or they could have anemia, fatigue, weight loss, or it could affect the eyes, causing Sjogren syndrome. Retinal vasculopathy, kidney, they could have glomerulonephritis or nephrotic syndrome, and joints, it could cause arthritis, rashes, and photosensitivity as well. So neonatal lupus is babies who are born to mothers with lupus or positive anti-Rho and anti-La antibodies. The babies will have immune cytopenia. They may present with rash or congenital heart block, which could eventually lead to hydrops and fetal death. So the congenital heart block is highly associated with anti-Rho and anti-La in the mother. What are the other features of neonatal lupus? They could either have increased liver transaminases or hepatobiliary disease in 10% of the cases. They could even have non-cardiac manifestations. Congenital heart block is diagnosed when there is a fixed fetal bradycardia of about 50 to 60 beats per minute when we do a routine ultrasound scan between 16 to 24 weeks on the fetus. And most cases are third degree heart block. The risk does not correlate directly with the maternal antibody titer. It can result in endocardial fibroelastosis and even fetal hydrops. The incidence of anti-Ro and anti-La in pregnancies is about 3%. Recurrences after a first index case could be as high as 18%. Mortality rate is about 20%. And a need for a pacemaker is more than 60%. And late onset cardiomyopathy is about 10%. So today I'm going to present about two interesting cases that we saw in UMMC. So far since 2013 until today, we have seen about 5 cases in which 3 were managed, two had pacemaker, and then 1 was managed conservatively, and then there were 2 other cases wherein there was regressed spontaneously. But in literature so far, we have seen that very rare for the complete heart block to regress to normal heart rate. But we had a case this year, which I will be discussing later, wherein the complete heart block reversed completely. So Madam NF, she was referred at 26 weeks for fetal cardiac abnormality, and a scan done by the feto-maternal consultant was diagnosed with complete heart block. She gives a past history of 1 year back. She had rashes over the face and legs, and it was diagnosed with SLE at a specialist hospital. But patient defaulted follow-up as she wished to conceive. Blood tests done for anti-Ro and anti-La, SSA, SSB were positive. She continued to have serial ultrasound scans. There were no structural cardiac abnormalities, no fetal hydrops. The atrial rate remained normal, whereas the ventricular rate was only 50 to 60 beats per minute. She was given antenatal corticosteroids for fetal lung maturity. The complement levels were normal. ESR was high. So the renal function and liver function remained normal. She was seen by the consultant rheumatologist and was on regular follow-up with them as well. Hydroxychloroquine was started, but however withheld owing to allergy and worsening vasculitis. She was regularly seen by the pediatric cardiologist. While we were doing her fortnightly scans, she was counseled about the prognosis. She was planned for a cesarean section at 36 weeks as there were some early signs of fetal compromise. So this is the ultrasound picture, wherein this is the atrial heart rate, and this is actually the ventricular heart rate. So the ventricular heart rate is about 51 beats per minute, whereas the atrial rate is 140, which is normal. So this is also another picture wherein this actually is this is the ventricular heart rate, and this is actually the atrial heart rate. So this is a Doppler ultrasound for the same patient, wherein the heart rate is only about 49 beats per minute. The amniotic fluid index shows oligohydramnios. This is the 3D view of the baby. The anti-Ro and anti-La was positive. So she also had the anti-nuclear factor that was positive. Anti-double-stranded DNA was positive. She was diagnosed actually with SLE. So elective cesarean section was done. Baby was intubated immediately, transferred to the cardiac theatre for pacemaker. A temporary pacemaker was inserted in the operation theatre and then managed at special care nursery. The birth weight of the baby was about 2.9 kilo. Initially, the baby was on temporary pacing, but later it was changed to permanent pacing when the baby was around 4 kilos. And she came for her second pregnancy after a few years, and the child was running around in the ultrasound clinic with the permanent pacemaker. So the management actually involves a multidisciplinary team approach, wherein the ONG team, the pediatric team, the peds cardiologist, cardiothoracic surgeon, and 2 anesthetic teams, one for the mother and one for the newborn, and the rheumatology team were involved. So these are some of the pictures wherein we actually did the surgery immediately. We took the baby out. There were 2 operation theatres. In one operation theatre, we did the cesarean section. The other cardiac theatre, the baby was intubated immediately. And then initially the heart rate was about 46 beats per minute. And then subsequently, the pacemaker was inserted by the cardiothoracic surgeon. It was a temporary pacemaker. And then the heart rate went up to 140 beats per minute. Okay, so the next patient that I would like to discuss is Madam G. She's a 33-year-old Indian lady, and she presented to us at 9 weeks of gestation in our antenatal clinic in Universiti Malaya Medical Center. She presented this year in 2022. So she had a recent diagnosis of Sjogren syndrome. Her symptoms 7 years ago was of prolonged dry skin and painful rashes of both lower limbs and upper limbs. However, she defaulted treatment. She was investigated in her early pregnancy and was diagnosed to have Sjogren's syndrome with immunoserology report showing positive anti-Ro and anti-La antibodies. She was started on azathioprine, hydroxychloroquine, aspirin, and prednisolone in her first trimester. During her anatomy scan that was performed at 22 weeks gestation, the fetus was noted to have congenital heart block with a ventricular rate of about 106. Initially, it was type 2 heart block. So we discussed with the rheumatologist and then we planned to admit her and start her on IV immunoglobulins. But then, however, patient refused treatment and then she defaulted and she went back. Fetal echo was performed after a week by the pediatric cardiologist. It showed complete heart block with no pericardial effusion. Atrium rate was 134 beats per minute. Ventricular rate was 93. There was a globular heart, normal 3-vessel view, and no regurgitation seen with intact ventricular septum. Subsequently, her fortnightly scans showed similar findings of complete heart block. However, when we did the scan at 28 weeks and 6 days of gestation, the fetal echo showed a spontaneous resolution of the complete heart block. Her findings showed a ventricular heart rate of 129 beats per minute, and the subsequent scans also showed no evidence of heart block. Spontaneous reversal was noted. Her subsequent follow-ups were normal. She had an emergency cesarean section, however, at 35 weeks of gestation for fetal distress with preterm delivery. A healthy baby girl was delivered with no complications and she was uneventful post-operatively. So this is the ultrasound picture of the patient. See, on 28th of January, there was a heart block. So this is the ventricular rate, which is about 95 beats per minute. However, on 14th of March, the heart rate became normal. Okay, so the atrial rate was about 128 beats per minute. The ventricular rate was also around 139 beats per minute, became normal. Sjogren's syndrome is actually an autoimmune disorder. It is typically occurs in women. The immune cells attack the exocrine glands. It could be either primary or it could be secondary when it's associated with other autoimmune diseases like lupus, rheumatoid arthritis, or scleroderma. So they could either present with dry eyes, dry mouth, throat, and nose, dental decay, oral yeast infections, digestion issues, joint pain, fatigue, and enlarged lymph nodes. So let's discuss about congenital heart block. It is a most serious complication of neonatal lupus erythematosus. There is transplacental transfer of maternal anti-Ro and anti-La antibodies around the 12th week of gestation, and this is associated with the development of the congenital heart block. So these antibodies may lead to inflammation, fibrosis, and scarring of the fetal conduction system in the early second trimester. Different degrees of atrioventricular block may be seen in the affected fetus. First and second degree AV blocks may change in severity. However, the third degree AV block is usually irreversible. Congenital heart block is mostly diagnosed between 18 to 24 weeks of gestation. It is recommended that antibody-positive mothers or mothers having babies with neonatal lupus should be referred for close fetal echo surveillance beginning from early second trimester. So the tissue injury in the fetus is presumed to be dependent on the FCAR-mediated transplacental passage of maternal IgG autoantibodies. These antibodies bind to the fetal cardiocytes and then they inhibit the normal physiologic removal of the apoptotic cells. So thus resulting in inflammatory reaction and fibrosis of the cardiac conduction system. The other possible mechanisms that are postulated are, it could be there is some cross-reactivity between the SSA and SSB antibodies and down-regulation of the L-type calcium channels or their inhibition by autoantibodies. Some of them even feel that the anti-Ro antibodies are arrhythmogenic. They have arrhythmogenic activity. So these finally, all these processes, what they do is they cause myocarditis, hemorrhage, fibrosis, calcification, and necrosis in the conduction system. So which result in the development of a variable degree of heart block, myocardial dysfunction, or endocardial fibroelastosis. So the anti-Ro antibodies, they bind to a cross-reactive molecule on the fetal cardiac cells. So there is some calcium dysregulation, apoptosis. The anti-Ro, anti-La antibodies bind to the apoptotic cells, and then there is antibody deposition and opsonization. the macrophages will engulf this apoptotic process and then debris, and then finally there is establishment of an inflammatory reaction in the fetal heart, fibrosis and calcification, leading to permanent damage of the fetal heart. So in the normal heart, an electrical impulse originates from the SA node and travels to the atrioventricular node and through the Purkinje system into the ventricles. Atrioventricular block results from immaturity or complete absence of the conducting system or from abnormalities at the level of the atrioventricular node. After one affected child, further pregnancies carry a risk of about 17 to 30% risk of atrioventricular block. Atrioventricular block is divided into three: first degree, second degree, and third degree heart block. First degree is a bit subtle and a bit difficult to diagnose actually. There is just a prolonged PR interval of more than 200 milliseconds. It results in a conduction delay, but without markedly abnormal rate or rhythm. So it's only appreciated in utero by measuring the PR interval on spectral Doppler tracing. The second degree heart block is with a blockage of single atrial beat, or there is intermittent conduction abnormalities. Usually when we pick up the heart abnormality, it is already second degree heart block. It could be the Mobitz 1 or 2 depending on the type of block. And then the third degree heart block is complete heart block. This one, I think all of us will be able to diagnose. The ventricular and atrial rates are entirely dissociated. So this is a spectral Doppler, wherein actually this is the ventricular rate. It shows much lesser when compared to the atrial rate, which is quite frequent. And this is actually another, M mode, wherein it shows this is the ventricular rate and this is the atrial rate. So first degree heart block, just the PR interval is prolonged, so it is a bit difficult to diagnose. Second degree heart block, there is dropped QRS complexes, which is quite easy to diagnose. And third degree heart block is also there is dissociation between the atrium and ventricle, so you can easily diagnose the third degree heart block. This is actually a M mode tracing, wherein the transducer goes through the right atrium and left ventricle. Actually, the ventricular rate is much slower, whereas the atrial rate is quite fast. The ventricular rate is about 50 beats per minute and the atrial rate is about 125 beats per minute. So this is how it looks. You can actually see this is the atrial rate, atrium, and the ventricular, M mode tracing. So this is actually the ventricular rate is very slow, whereas the atrium is actually beating at the normal rate. So this is also another clip wherein you can see there is dissociation between the atrium and the ventricles. So this is the atrium, this is the fourth chamber. Yeah, so you can see, once you see this fixed fetal bradycardia, you know there is complete heart block. So this is a hydrops fetalis, wherein actually the heart is surrounded by the pericardial effusion and there is pleural effusion, the lung is collapsed. This is a complication of complete heart block. Prognosis of complete heart block depends on underlying structural heart disease, the ventricular activation if it is less than 55 beats per minute, and whether there is presence of or absence of congestive heart failure, and whether there is hydrops fetalis or a sudden rapid drop in the heart rate, or endocardial fibroelastosis, or if it is associated with dilated cardiomyopathy or valvular dysfunction. Low birth weight babies, male sex, delivery less than 34 weeks of gestation, complications from prematurity or neonatal lupus are also leading to poor prognosis. Jeggi et al., he reported a mortality rate of about 43%, and then Kurtz et al. Reported 30 to 53% had associated congenital heart disease. Autoimmune isolated congenital heart block, usually 85% survival. And the need for permanent pacemaker is more than 60%. And the late onset cardiomyopathy is about 10%. So now that we know about complete heart block, let's see how to manage. In utero treatment of the fetus with the first degree heart block is primarily expectant. The fetus will tolerate the slow escape rhythm in majority of cases. Prenatal treatment with glucocorticoids, that means oral dexamethasone was given 4 milligram per day. It is suggested for mother of fetuses with second degree heart block, beginning as soon as after detection this is feasible and continuing through the end of the pregnancy. Treatment of third degree block with glucocorticoids is controversial. It is generally not advised. Glucocorticoids are also considered for more global cardiomyopathy. Preemptive treatment with hydroxychloroquine, 400 milligram per day in pregnant women with anti-Ro antibodies is recommended. So various therapeutic regimens have been tried, in utero treatment using sympathomimetics, plasmapheresis, steroids, IV immunoglobulins, digoxin, diuretics, and in utero pacing as well. But however, the usefulness of these treatments still remains controversial. So fetal echo is a very important tool in the management of congenital heart block. Fetal Doppler mechanical PR interval requires training. Prophylactic steroid therapy is controversial. Beta-adrenergic agonist is also controversial. Salbutamol may be used when there is deteriorating cardiac function. Patients with an adequate ventricular heart rate and no symptoms can usually be followed with serial observation, while the symptomatic patients will require a permanent pacemaker. Early pacemaker therapy is recommended in patients with symptomatic bradycardia and ventricular dysfunction. The indications for pacemaker would be symptomatic bradycardia or low cardiac output, wide QRS escape rhythm, complex ventricular ectopy or ventricular dysfunction, infants with a normal anatomy, but however the ventricular rate is less than 55 beats per minute, or infants with structural congenital heart disease and a ventricular rate of less than 70 beats per minute, or children beyond the first year of life with an average heart rate of less than 50 beats per minute. So this is how the pacemaker is inserted. This is at 8 weeks. This is at 5 years of age. This is a permanent pacemaker. So the take-home message of my presentation today would be fetal echo should be done as a routine screening. It's a very essential tool between 18 to 22 weeks of gestation to detect fetal cardiac anomalies. It is a non-invasive test. Early detection could help the patient to be transferred to a tertiary center for further management. Knowledge of the complex congenital heart disease before delivery will allow for therapeutic interventions, for counseling patients, and to begin immediately treatment after birth, and can be a life-saving measure for such patients. And multidisciplinary team approach is very essential in the management and better outcome of these babies. This is how we do a fetal echo. Actually, the baby should be in a mid-sagittal position with the fetal heart facing up, and the baby should be facing up as well. So this is the best position for doing a fetal echo. This is actually a 4-chamber view of the heart. And these are all the outflow tracts. This is actually the right ventricular outflow tracts, and this is the left ventricular outflow tract, and this is the apical view of a 4-chamber heart. So these are the images that you would like to see to check, to show that it is a normal fetal heart. So thanks to everyone for participating in this breakfast show. And thanks to all the teams that were involved in the management of all our patients, the special care nursery, cardiology team, rheumatology team, cardiothoracic surgery, as well as the anesthetic team.
Thank you very much, Prof. Wali. It's excellent presentation on the 2 cases of patient with congenital heart block. I think we can, anyone who has any question can put it in the Q&A chat box, and we can try to answer it live. But please remember that we are, as a tertiary hospital, we have a lot of patients with SLE, and they do get pregnant and referred to us, and therefore we got a lot of patients with SLE. And but remember that not all patients with SLE will have a congenital heart block for the baby. So we need to look at the anterior and antilla. So Prof. Wali, there's a few questions here in the chat box. So I think we kick off with the Prof. Tunku Sarah question. So the first question is, do the babies suffer from lupus after they are born if safe by pacing?
Actually, they do. If it is neonatal lupus, they could present with other conditions also. They can have the rashes, or they could have the liver problem and all that. But usually pacing is just for the heart problem. It's been managed by pacing.
Okay. So they still have a risk of getting SLE. What is the answer is actually the pacing can actually save the heart.
The heart. Yeah, the baby.
So the next question by Prof. Tunku Sarah is juga. So how did the second child actually convert spontaneously despite mom refusing the treatment?
We just don't know. But she was on hydroxychloroquine. She took hydroxychloroquine, but she refused all the IV immunoglobulin and then oral DEXA and all that. Probably, but in literature, it's controversial, the use of all these to help in the management. But I looked at the literature. There is no articles actually saying that it will complete heart block will reverse to normal. But we've had a patient actually reversed. It's good for the patient. She's so happy.
Good. Yes, good for the patient. I think not all with positive anti-Ro anti-La will have congenital heart block. So there's a potential that it will revert spontaneously. So probably it has at the beginning, but it will revert to normal back. Okay, the next question is in a healthy first-time mother, do you routinely measure fetal heart rate of both atrial and ventricular heart rate?
If both the atrium and ventricular is beating at the same rate, we don't separately measure because the M mode, when we put, it will be the same. The heart rate will be the same for atrium and ventricle. If the mother is healthy, there wouldn't be difference. Only when there is AV dissociation, then you can see the atrium is beating at a different rate when compared to the ventricular rate.
Okay. All right. Any other questions? We don't have any more question here. But what are the conditions, Prof. Vali, that actually can cause congenital heart disease that you normally see in the clinic? So apart from the SLE.
All the autoimmune conditions can cause autoimmune congenital heart block, but if the heart has got other abnormalities like all this heterotaxy syndrome and all these structural malformations of the heart also can cause congenital heart block. So we have to make sure there is no structural malformation in the fetal heart.
Yes. Okay. So, all right. I think that's all the question. But the take-home point here is if you do have a patient with SLE and they get pregnant, so please refer to us as early as possible so that we can have some intervention that we can do in utero. Also, we can actually plan like what Prof. Vali has highlighted just now, that we can just do post-delivery pacing that we can actually save the child. All right.
Yeah.
Okay, I think that's all for now. So we are actually quite early, 4 minutes early than the timing. So shall we move on to the next? The next one is I would like to actually introduce the next speaker. It is Dr. Masyithah binti Ma'ruf. She's going to talk on the urinary incontinence to refer or not. Dr. Masyithah is a clinical specialist and senior lecturer in the urology department of surgery. And she graduated from in 2003 and get a master in 2012 and from the same university of her undergraduate. So she had a urology and obtained her FRCS from University of Glasgow, United Kingdom in 2018. And in 2020, she completed her fellowship in Bristol Urology Institute, United Kingdom, in female and functional urology and endourology. And prior to that, in 2017, she underwent 2 months training in urogynecology at Kamida Medical Center in Japan. And throughout her career, she presented various time at local and international urology conferences. And she also appeared often on radio and television shows to talk on urology topics, especially those related to female and functional urology and endourology, which she is highly passionate about. So without further ado, let us invite Dr. Masyithah to deliver her talk. Masyithah.
Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to everyone. Thank you for listening to today's program. I'm greatly honored to be chosen by the Department of Surgery to represent the department. And my topic for today is very interesting, not as heavy as Prof. Vali's topic, but I hope that everyone will enjoy listening to it. And at the end of the talk, everyone will benefit from it. And if you do have any question, kindly please put it down in the Q&A box. Okay, let me just start with the screen sharing. Okay, so urinary incontinence, to refer or not to refer. I am Dr. Siti Masyithah binti Ma'ruf from the Urology Unit, and this is the logo of UMMC Urology. Okay, so what is urinary incontinence? We listen to patients, they complain to you. So based on the International Continence Society, it is defined as involuntary loss of urine. So what actually happened? There's a few types of urinary incontinence. These are a few common types that we see day in and day out in our practice. And, we have things called the stress, the urgency, the mixed, continuous, overflow, and also disability associated. So what is actually stress urinary incontinence? This is a situation where the patient lost control of urine when they were to cough, there's increased intra-abdominal pressure, or, when they were to do certain exercise, certain maneuver, running, playing badminton, playing tennis, and all those things. So basically, stress urinary incontinence is leaking of urine that happens when a patient has increased intra-abdominal pressure, even in pregnancy, for example. Next is urgency urinary incontinence. This is associated with patient who suffers from overactive bladder. So what happened in this group of patients is that, they have the sense that they need to go to the toilet. They feel that they need to rush to the toilet. Before they get to the toilet, before they are able to undress themselves to pass urine, they tend to leak urine. Next group of urinary incontinence is mixed urinary incontinence. This is a combination of stress and also urgency. This is very common in ladies based on the research and all the literature that we have seen so far. How about continuous urinary incontinence? Continuous urinary incontinence indicate that the patient leaks urine continuously, day and night, throughout the whole day, and it doesn't stop at all, whether it's a lot or little. But they do complain to you saying that every time they feel that there's wetness down at the perineum region. So what causes continuous urinary incontinence? It can be congenital. It can be something recent. For example, a patient had a hysterectomy, has cesarean section, fistula has been formed within the ureter and the vagina, so they tend to leak urine. Now, these are the kind of scenarios that patient were to give to you when they complain that they have a certain amount of continuous urinary incontinence. Next is overflow urinary incontinence. This is a situation where we usually see in patients with neurogenic bladder. What is neurogenic bladder? Neurogenic bladder is a situation where the patient has some form of bladder dysfunction due to a certain neurological abnormality or a certain neurological insult. For example, multiple sclerosis, injury to the spinal cord, patient had Parkinson, or, not just that, patient might also have a chronic retention due to enlarged prostate over a long period of time. So what actually happened in overflow incontinence is that, as all of us are aware, bladder is made of muscle, the detrusor muscle. It has a maximum capacity on how much urine it can actually contain. So when the maximum capacity has been reached, the urine has nowhere to go. Therefore, it tends to leak out. So this is called as an overflow incontinence. So what patient usually persists is that they're actually passing urine. But no, they got that wrong because they're not actually passing urine. This is just purely leaking of urine because the bladder is completely filled up. The next category, which we usually see, is a disability associated. Disability associated urinary incontinence can be due to physical disability or mental disability. In other words, patient has, rheumatoid arthritis of the knee, they don't get to the toilet on time, so they tend to leak urine, or the patient has dementia, they don't remember that they has not gone to the toilet, or they just could not go to the toilet on time because they can't think right. So those are a few urinary incontinence that we see day in and day out in our practice, not just in urology, but I'm sure those in the gynae side, the obstetric side, the geriatric, you do see this quite often. So I'm here to share what I know. So hopefully, we can help this patient accordingly to reduce their bothersome symptom. Okay, many of you might ask, who is more susceptible to urinary incontinence? Is it related to the male? Is it related to the female? So I would like to bring your attention that, it doesn't matter, male or female, this group of patients are still prone for urinary incontinence. Yes, I do agree that if you have to look in the literature, urinary incontinence is mainly associated to female. But again, please do not forget that men can also suffer from leaking urine involuntarily. What are the risk factors? First of all, women of any age are prone for a urinary incontinence. Women has more tendency of developing overactive bladder throughout their life, and especially those who have gone through pregnancy, gone through delivery. They might have injury to the perineum muscle or the overstretching of the perineum muscle during delivery, forceps delivery, vacuum delivery. They because of the weakness of the pelvic floor muscle during this scenario, delivery and pregnancy, they tend to leak urine more often, and they are always related to stress urinary incontinence. Same goes to group of elderly, because of muscle weakness of the perineum and the pelvic muscle that support the bladder, they tend to have urinary incontinence. And at the same time, moving around might be a bit more difficult when you age. So they tend to also have disability, urinary incontinence. As for obesity, you have a whole, a heavy fat pad around the lower abdomen. This can cause pressure to the bladder. So those who are obese have higher possibility of suffering from stress urinary incontinence. Chronic smokers also related to urinary incontinence, and same goes to diabetic patient, because we know, diabetes patients tend to, are more prone to infection. UTI is more prone in them. They tend to leak urine, and also because of the muscle weakness of the detrusor muscle, and also it can also affect the spine. It can become neurogenic bladder at the end of a long course of diabetes, especially in uncontrolled diabetes. Same goes to those with chronic cough. Stress incontinence is related to that. Patients have tuberculosis or, post-COVID, some patients tend to cough. They don't go for treatment. They might leak urine because of stress urinary incontinence, increased intra-abdominal pressure. Wheelchair-bound neurogenic bladder related also to urinary incontinence. I would like to draw attention to excessive coffee, tea, and also alcohol. All this caffeinated drink, also alcohol, can cause, they are diuretic in a way. They also can irritate the bladder and cause patients to have urinary incontinence if they do not get to the toilet on time, especially urgency incontinence. An interesting fact over here is constipation. If a patient has a fecal-loaded rectum, it causes pressure to the bladder. And this can also cause urinary incontinence, which is related to stress, because there's an external pressure pressing on the bladder. So these are a few risk factors that I would like, to enlighten everyone. Maybe, we don't really look into this when we go to treat our patient, but, think again, because the solution might be just coming from the risk factor. Okay, the big question for the day. Must all cases of urinary incontinence be referred immediately to the urologist? I'm sure, majority of us listening today are doctors. We can always help the patient and do, simple things, basic things. Because as we know, waiting time to see the urologist in most hospitals takes about 6 months. Do we want the patient to suffer that long? Is there anything that, we can help or you can help so that the patient will be less bothered by the leaking urine? How can you help? What can you do? First of all, history taking is very important in any medical problem. Please remember that urinary incontinence is not a disease. It is a symptom where the patient complains to you. So what do you need to know? Ask them about the duration. How long has this been bothering them? Is it something new? Is it has been there for years? The severity, the amount of leak. Is it leaking just on and off, or is it leaking every day? Do they need to use pad, liners, or maybe they even have to be on urinary catheter? Determine the type of urinary incontinence, because this will assist you on how best you can manage the patient. The risk factor. That's another thing for you to consider. And does this patient has any surgical intervention before? Any abdominal surgery? Any gynecological surgery, for example? Any medical problem, diabetes, or any neurological problem? Any spinal cord injury? Drug history is also very important at the same time, because as we know, certain medication like furosemide, has Lasix property, and this might cause the patient to produce more urine. And if the patient, has a very poor compliant bladder, they might not be able to hold the urine very much. They might have urinary incontinence. And also psychotic drugs are also related closely to urinary incontinence. The drinking habit, caffeine intake, alcohol intake. And please ask the patient if they had certain treatment being given before for their urinary incontinence, so that you can try something else. Focused physical examination is very important. BMI, is the patient obese? Any surgical scar on the abdomen? Any palpable bladder, indicating that this might be a overflow incontinence? Bloatable kidneys, might have a mass there, or because of reflux, any abdominal mass causing compression, such as an ovarian tumor, for example. And it's also very important in elderly female, if there is any pelvic organ prolapse. Have a look down below, because I think, most of us as doctors, sometimes we just not that interested to look down below. External genitalia for elderly men, those who have, what we usually see is that patient complain of leaking urine. Actually, what we see is that it's an uncircumcised foreskin, pinpoint foreskin. So what actually happens is that the patient is unable to empty his bladder, and therefore he tends to leak urine, which is collecting at the adhesion at the prepuce. No any skin excoriation at the perineum, indicating that this kind of urinary incontinence has been ongoing for quite some time. Kindly please do digital rectal examination. Look for the anal tone. Is there any compromise in the anal tone, which indicates that this might be neurogenic? Any fecal loaded? Is the prostate enlarged and things like that? Which might be related to the cause of urinary incontinence. And if based on the history, you think that the patient has a significant neurological deficit, you can also proceed with a neurological examination. Baseline investigation, do a urinalysis. And if it is due to UTI, do a urine culture. And for all you know, if you were to treat the UTI, problem is solved and patient doesn't be bothered anymore with the urinary incontinence. If you think that the patient has some kind of renal failure, distended bladder, some kind of obstructive uropathy, hydronephrosis, do a renal profile. Have a rough idea how bad or how good is the renal profile. If the prostate is enlarged, nodular, do a PSA. You might be actually looking at the prostate cancer over here, and the treatment will be completely different. Ultrasound, kidney, ureter, bladder, if you think there's any clear indication for it, renal profile is deranged, for example, and also ultrasound abdomen pelvis if there is a abdominal mass palpable during your examination. So all this baseline investigation is catered, customized to the patient, to whatever you think will work best for you to help the patient and for you to diagnose the disease, the urinary incontinence that the patient is suffering from. Treatment. There are a few treatments that you can help the patient with, that you can, tell the patient. So it depends on what type of urinary incontinence that you're dealing with, how severe it is, and what other underlying causes. You might need combination treatment for the patient. And, if the underlying condition is causing the symptoms, you need to treat this first. For example, if there is a huge ovarian mass, removing the mass, referring this patient to your gynecology colleague might be the solution, because there's no more external compression, the patient will not suffer from stress urinary incontinence. Remember, when you treat a patient, I'm sure that this has been, all of us are practicing this. We start with the less invasive treatment first, followed by other options if these simple techniques fail. So what can you do for this patient? Simple things first. Lifestyle modification might just be one of the solutions for the patient's problem. Food and diet management. Tell the patient, do not drink too much coffee, do not drink too much tea if they are bothered by urgency incontinence. Bladder training. So what I mean by bladder training is that if you have an elderly lady who have, impaired mobility, you can tell her or tell her caretaker to bring her to the toilet every 2 or 3 hours, depending on how much she drinks. Because sometimes they tend to forget to go to the toilet and they try to rush to the toilet when they really have that urgency to go to the toilet. And because of their disability, they do not reach the toilet on time, they tend to wet themselves. So same goes to double voiding. They might not be able to empty their bladder completely on the first time, for example, in cases of enlarged prostate. So tell them to double void. Losing weight might help for stress incontinence in obese patient. Quit smoking and also treat constipation. Those are fairly simple, which I'm sure every doctor can assist the patient to get to this point. You can also recommend patients to go for pelvic floor exercise. I'm sure a majority of us are aware of Kegel exercise, and Kegel exercise is not just for ladies, it can also benefit men. So what does it do? It strengthens the muscles that support the urinary system. It can be useful for stress and also urge incontinence. Refer them to the physiotherapy if you're not sure how to teach the patient, because sometimes you are just so pressed for time in clinic, we don't have time to go through to them about how to do it and things like that. You can refer to our physiotherapy colleague. They are more than helpful and more than happy to assist this patient. Again, it is very important for you to remind the patient that physiotherapy, pelvic floor, Kegel exercise is not a solution that happens overnight. They have to do it consistently, correctly, for at least 4 to 6 weeks for them to see some kind of improvement. Give them a scenario like going to the gym. If you want to have 6 packs, you cannot just get 6 packs just over 1 or 2 weeks of, on and off gym workout. You have to be consistent. You have to be persistent. So, you put this idea into them so that they do not get disappointed at the end of the day when they see that it doesn't work. It doesn't work maybe because they don't do it correctly. So how can they do it correctly? If you refer them to the physiotherapist, there's a few instruments, there's specific adjunct that can assist the patient to make sure that they're doing the Kegel exercise properly. In UMMC itself, they have this machine called the biofeedback machine, MYO420. So what happened is that they have this electrode where they attach at the perineum region, and when the patient were to contract the muscle, when the correct muscle is being contracted, it will be highlighted on the machine. So the patient knows what is wrong and what is right. So when they go back and they were to do it themselves, they will do it correctly. Same goes to the educator. It's a kind of probe being inserted to the vagina. You have an antenna at the end. So when the patient were to contract the right muscle, the antenna will go up and down. So this indicates that the patient is doing the Kegel correctly. Rectal probe, vaginal probe to assist the patient to tell them they are doing they're contracting the right muscle. You also have these more expensive gadgets such as the Aquaflex. This is also available upstairs in the physiotherapy room. And if the patient is a bit well-to-do, they can buy LV. LV is a device which is a biofeedback device. You have the green device down below, which is being inserted to the vagina region. Then you have a Bluetooth connection to the handphone, and the patient can actually see that they're doing it correctly, because it will show the patient how many seconds of contraction, how strong the contraction. Are they contracting the right muscle? LV is being used widely in the NHS. I think it's quite pricey. All in all, it's about it's about Ringgit Malaysia 1,000. But if the patient can afford it, they don't mind buying it, this is a good option. So when they were to go back, they can actually do the Kegel exercise properly. Other non-surgical treatment for those patients who are suffering for urinary incontinence, you can use liner, pads, diapers, containment product, such as the urinary catheter, either per urethra, suprapubic, or also condom catheter. We also have this special device called the penile clamp. Okay, this is an example of a penile clamp. There's various types of penile clamp in the market. For example, patient is not the urine leakage is not too troublesome. For example, a patient needs to go for haji, for example. So Pakcik tells you, I tend to leak urine. It's very difficult for me to pray. But I don't want to do all this, advanced maneuver, because, well, it's not that troublesome. But if I have a certain device that can assist me to go through Hajj, for example, it's Hajj season at the moment, you can suggest them penile clamp. So what they do is that they were to put it at the end of their penis. So when they want to go to the toilet, they just release it. They can buy a few. It's washable. They can make sure that they interchange it, make sure that it's dry before they apply it to the skin. It's fairly safe to put it there, but when it's off prayer time, they can remove it, so at least you don't cause any unnecessary ischemia to the penis. And also vaginal pessary being inserted by the gynecology colleague, obstetrician. It can also help patients if they have a certain amount of pelvic organ prolapse causing urinary incontinence. Okay, drug treatment. Alpha blockers, topical estrogen, anticholinergic, beta-3 agonists are a few drugs that can be prescribed to the patient to assist them to reduce the bothersome symptom of the urinary incontinence. Alpha blocker is suitable for prostate enlargement patient, especially those suffering from urge and overflow incontinence. Common examples are doxazosine, Hanal, afuzosine. Topical estrogen, it helps to rejuvenate the muscles down below in elderly lady, menopausal lady, because this can help in urge incontinence to a certain extent. Same goes to anticholinergic, tolterodine, physotyridine, solifenacin. It does help in a certain group of patients, but however, anticholinergic can cause severe dry eye, severe dry mouth. So you need to tell your patient about that. If they are bothered by anticholinergic side effects, you can always try beta-3 agonist. The one that we have in the market at the moment is mirabegron, or it trades name as Betmega. Okay, you have tried everything. Patient still comes to you and say, no, Kegel doesn't work, the medication doesn't work, I want to see the urologist. Well, my team over here is more than ready to serve the patient, to treat the patient, and try our very best to help them in any way that we can. So what are the different things that we can do? What are the extras that the urologist team can do? Okay, history taking, physical examination, basic baseline investigation, treatment, all of you has helped us through that. So we can skip the earlier part. We can concentrate on a more advanced or a more something more than what we had done before. Bladder diary is one thing. So what is a bladder diary? We will ask the patient to chart 3 days and during their normal daily activities. They chart where they drink, how much do they drink, the type of drink, coffee, tea, plain water, the time that they consume this drink, and the time when they urinate, and if they have any leaking in between. They were to write down everything. by time on a piece of paper. So they were to do over 3 days. So when they come to the clinic, we are going to have a look at the bladder diary, so we know how best we can help the patient, because sometimes patient doesn't really know that, you know, they're drinking too much, or they're drinking or they're, you know, they're just consuming a bit too much, especially before bedtime and things like that. So when we have all these things written down objectively, we can advise the patient accordingly. We can tell them, look here, this is what you'll be doing, this is what you can do, you can avoid, so that, you know, you don't suffer from urinary incontinence. Next is uroflowmetry, and also post-void residual urine measurement. So what we have this special machine where we ask the patient to pass urine. We want to see how much urine that they are passing out. You know, for all you know, they might not actually emptying their bladder correctly, or emptying their bladder completely. So because of this, they tend to have a high post-void residual urine, and this can cause overflow incontinence. So we can, you know, get a rough idea on how good or how bad their bladder is working for them, and we can assist them in that particular area. If we think that this patient will warrant other relevant investigation, what we can do is that, what urologists can do, we'll proceed for flexible cystoscopy. So what can we do in flexible cystoscopy? For all you know, patient might have urethral stricture, or that there might be a bladder mass, there might be some bladder stone causing irritation to the bladder. And, you know, by solving this problem, you know, treating this bladder mass, treating this bladder stone, that might be able to cure the urinary incontinence that the patient is suffering. Next is urodynamics. Urodynamics is a pressure flow investigation. So it gives us an idea what can we do for the patient. Is it a bladder problem? Is it a voiding problem? You know, how best that we can plan for the patient subsequently. Most of the time, urologists will decide on urodynamics when we have dilemma on to diagnose the patient. Is it stress? Is it overflow? You know, is it urgency incontinence? Should we offer surgery for the patient? Because as we are aware, you know, offering surgery for the patient has complications to it. So we want to make sure that, you know, when you decide for surgery, you are deciding the right kind of surgical treatment. And, you know, we want to avoid patient from complication if the surgical intervention is not actually necessary. So let me bring your attention to surgical treatment that we can offer for stress urinary incontinence patient. Urethral bulking agent is a procedure where we were to inject bulking agent into the bladder neck. You know, this will actually cause the bladder neck to be slightly narrow. So when the patient were to cough and sneeze, they don't leak urine too easily. Colpo suspension can be done by either urologist, urogyne, sorry, you know, where you actually bring up the bladder so that it doesn't fall easily when the patient were to cough and sneeze. And I'm sure all of you are aware about slings. You know, we have TVT, we have TOT. Autologous fascia sling is where you harvest the patient fascia, you know, abdominal fascia, and this can create a hammock to the bladder neck, and this avoid the bladder from falling down into the urine when they were to cough and sneeze. We have also male sling and also artificial urinary sphincter. I would like to bring your attention that stress urinary incontinence is not very common in male. Gentlemen who are prone for stress urinary incontinence is usually related to those who had radical prostatectomy. This is because our male counterparts are blessed with two external and extrinsic and intrinsic urinary sphincter. So what happened is that when they were to go for prostate surgery, one of the sphincter is being removed. Therefore, they tend to suffer from stress urinary incontinence. And in certain scenario, it might be very severe. It might require male sling. Artificial urinary sphincter can be used for female and also for male patient. How about urgency urinary incontinence? There are certain surgical treatment that can be offered to the patient. The urologist can offer intravesical Botox injection. So what does Botox do? Botulinum A toxin. They actually paralyze the detrusor muscle. By the paralysis of the detrusor muscle, the overactive bladder will be tamed down. The bladder will not be too irritable, and hopefully the patient they don't really have that sense of urgency too much. They can wait to go to the toilet on time, and they can pee without wetting themselves. Next is PTNS, percutaneous tibial nerve stimulation, and also circular neuromodulation as some kind of nerve conduction maneuver where you actually, it's like a pacemaker for the bladder. We reprogram the bladder to actually pass urine when it's time to pass urine, and they do not pass urine just because of urgency incontinence. The next few surgery is more advanced, so we reserve it to patients who failed a more simpler surgical approach, we have augmentation cystoplasty surgery. So what happens is that in the detrusor muscle in overactive bladder patient, it tends to be overactive. So what you do in augmentation cystoplasty is that, you split the bladder into two. In other words, you disconnect the nerve in the bladder from left to right lateral wall, so that, and you put a patch of small bowel in between. So this will actually reduce the overactivity of the bladder, and hopefully patient will fare better after the surgery. The last but not least is urinary diversion surgery. These are things like ileoconduit, where you remove the bladder completely. You don't really remove the bladder, but you don't use the bladder anymore. You divert the urine into an ileoconduit, and the patient will have a stoma on the abdominal wall, and they will not suffer from the urgency incontinence anymore. All right. That is all that I have for everyone today. Thank you so much for listening, and I hope that everyone has benefited from the simple talk. Thank you.
Thank you very much, Dr. Masyithah.
Welcome.
So, okay, so we move on to the question and answer session. So please put your question in the chat box, Q&A chat box, so that I can actually read it out. And it's actually an excellent talk that we actually is closely related to gynae, okay, because your interest is more to female, and we actually look after female as well on the incontinence. So how do we go about the devices, Masyithah? So do all urologists has the accessibility to that, or just refer to you for female patients?
Well, you can always refer to my team. It's a big team, so urodynamics can be utilized by anyone. The devices, the one for the physiotherapy is with the physiotherapist, is not with us. For the surgery, yes, if you are planning to do certain surgery like the tips and whatnot, I will actually perform it for the patient. But the rest, like the flexible cystoscopy, the urodynamics test, those can also be carried out by my team themselves.
Okay, that's excellent. So we can actually, after listening to your talk, so if our urogynecologists can handle, so we can handle ourselves, but of course we can refer to the urologists after that. Okay.
Yeah,
so,
there's some question in the box.
Yes,
yeah.
Prof. Shirin has said that thanks, Masyithah. So reminder to the audience that any continuous urinary incontinence in a female child should be referred to a pediatric urologist to evaluate for congenital anomalies and abnormalities. For example, abnormal insertion of the ureter, congenital fistula, and cloacal anomaly. Yes. So I think that's a good reminder. So we can still refer to pediatric surgeon for any abnormalities or any urinary incontinence. Okay. And
because in Prof, we for the urology team, we only treat adult urologists. So like what Prof. Shirina has mentioned here, any pediatric patient with urinary problem, they can always refer to the pediatric urologist. They do have pediatric urologists in UMMC and also outside in the KKM site. Yeah.
Okay, that's excellent. So the next question is, thank you for the excellent talk. So if, what if I have a postmenopausal woman with urinary incontinence, do I refer to a gynecologist or urologist?
Well, there's no hard and fast rule over here. You can always refer to the gynae, you can always refer to the urologist, but again, have a look down below. If the patient has a certain amount of pelvic organ prolapse, it will be advisable for you to refer to the gynae first, so that they can apply pessary for the patient. On my side, we do not do pessary. We usually refer to our gynae colleague to help with the pessary insertion. But if the patient doesn't have any pelvic organ prolapse, we are more than happy as the urologist to accept this kind of referral. Thank you so much.
So on behalf of the gynecology department, so probably if a patient with postmenopausal, incontinence, so we have to actually assess whether it can be actually helped by hormonal treatment first, or if there any like topical treatment that we can use, and what do they mean by incontinence? So like what Masyithah has highlighted, so we have to explore more on the incontinence, and we can usually manage ourselves, but of course, we can refer to urology if needed, the expertise. All right. Okay. All right. There's another one here. How do you manage flow incontinence or enuresis in general?
Okay, thank you so much for the question. For enuresis, we have to identify what. So first, is it adult? Is it pediatric? So if it's pediatric, then the treatment is completely different. So for adult, is it something that has just occurred recently? Because in some patients that we see with enlarged prostate, they tend to suffer from enuresis. So if that is the cause causing the enuresis, we need to treat the prostate, either with medication or with surgery. Again, history is very important. Based on the history, physical examination and investigation, we will type down the diagnosis, and from there we will try our very best to assist this patient. So the common example that we see in urology, the enuresis is due to enlarged prostate. So I'm not sure about pediatric. We can ask our pediatric colleague next time about enuresis in pediatric group of patients. Thank you.
Okay, I think that's all the question in the box. So I think we are 1 minute before 9. So I think an excellent talk, and the speakers has actually been complied to the time given. And I think if there's no more question, we can close the breakfast at UMHealth today. And I hope that everyone will happy and get some information from the 2 talks that we have had today. And we will see you next week then. Thank you.
Okay, thank you. Bye.
Thank you, everyone. Thank you.